Welcome to The Explainer. Today, we are tackling a field that has completely transformed over the last few decades, adult congenital heart disease. You see, these patients who once might not have survived childhood are now living full adult lives. And that means they're not just in pediatric hospitals anymore. They're in your clinic, on your wards, and you are on the front lines of their care. So let's just kick things off with a number that might surprise you. Somewhere between a quarter and a third of the entire population has a part of their fetal circulation, the foramen ovale, that never fully seals shut after birth. Just think about that for a second. Up to 3 out of every 10 people you meet are walking around with this. Now, this is called a patent foramen ovale, or PFO, and most of the time, it's no big deal. But what its prevalence shows us is something huge. Congenital heart issues aren't just these incredibly rare, complex cases. Nope. They exist on a whole spectrum, and understanding that spectrum is now a fundamental part of modern internal medicine. So why this massive shift? Well, the simple answer is that the patient demographics have completely flipped on their head, and that has a direct impact on your role as a clinician today. This right here, this is the single most important trend to understand. It's honestly a massive success story. Thanks to incredible progress in pediatric cardiology and surgery, patients are surviving and thriving into adulthood. It's amazing. But it also means they're coming to you with a whole new set of medical needs. And here's the key takeaway for you as a trainee. You are not expected to go it alone. Not at all. The best care is team-based. Your job is to be an absolutely vital member of that team, to have that high index of suspicion, and to know when to pick up the phone and get a specialist involved. All right, let's dive into our first major category of defects, the classic holes in the heart. Physiologically, what we're talking about are left to right shunts. So oxygenated blood from the high-pressure left side of the heart gets abnormally pushed back over to the low-pressure right side. And this is the core problem that creates. Think of it like this. The right atrium, the right ventricle, and the pulmonary arteries, they're suddenly forced to handle way more traffic than they were ever designed for. Over years and decades, this constant volume overload makes them stretch, get bigger, and eventually start to fail. Okay, this table is pure gold, both for your exams and for the wards. It neatly ties the defect to the sound you'll hear and the structural changes you'll see. For an ASD, an atrial septal defect, you're listening for that classic fixed splitting of S2. It doesn't change when the patient breathes. For a VSD, you'll hear that harsh holosystolic murmur. And for a PDA, well, that's the unmistakable continuous machinery murmur. So when do we actually need to step in and close these holes? Well, the rule of thumb is actually pretty simple. You look for the consequences. If the shunt is big enough that you can see the heart chambers starting to stretch and enlarge on an echo, that's your sign that it's probably time to consider closure. All right, let's switch gears. We've talked about problems of too much volume. Now let's talk about the opposite problem, problems of too much pressure. This happens when you've got a lesion that creates a blockage, obstructing the flow of blood. So how does the heart respond to a blockage? Well, it's got to work harder, right? Instead of stretching out, the muscle has to squeeze much harder to push blood past that obstruction. It's like it's hitting the gym every single day. And over time, that muscle gets thick and bulky, a condition we call hypertrophy. The classic example of this on the right side of the heart is pulmonary stenosis. You'll hear that distinct crescendo-decrescendo murmur, usually with a systolic click. That's the sound of the right ventricle straining against a tight pulmonary valve. The good news here is that treatment is often a minimally invasive balloon procedure to stretch that valve open. Now this is such a cool and classic finding. Aortic coarctation is a narrowing of the aorta, and it creates 2 totally different pressure zones in the body. You get high blood pressure and strong, bounding pulses in the arms, but low blood pressure and weak, delayed pulses in the legs. It's why you have to check for a radial femoral delay in any young person with hypertension. And that physical exam finding we just talked about, it has a classic counterpart on the chest X-ray that you've got to know. It's called the figure 3 sign. It's created by the shape of the aorta above and below the narrowing. It's a direct link from the bedside to the radiology suite. Finally, let's touch on our most complex group of patients, the cyanotic patients. In these conditions, the plumbing is essentially rerouted, causing deoxygenated or blue blood from the right side of the heart to shunt over to the left side and enter the main circulation. Tetralogy of Fallot, or TOF, is the most common cyanotic lesion you'll encounter. By definition, it's made up of these 4 specific anatomic features: a VSD, pulmonary stenosis, an aorta that sits over that VSD, and As a result of all that, right ventricular hypertrophy. The vast majority of adults you meet with TOF will have had it repaired as a baby. Now, for a patient with repaired tetralogy, it is so important to remember that their story isn't over. That initial life-saving surgery often involves widening the pulmonary outflow tract, which can make the pulmonary valve very leaky. This severe pulmonary regurgitation is the #1 long-term issue, and it often leads to another surgery decades down the road to replace that valve. This is really the tragic end-stage consequence of a big, unrepaired left-to-right shunt. After decades, the constant high flow to the lungs causes irreversible damage and severe pulmonary hypertension. Eventually, the pressure on the right side of the heart gets so high it exceeds the left, and the shunt actually reverses direction. At that point, it's the point of no return. Closing the original hole would be fatal. Okay, this slide is just packed with practical, life-saving advice. For any patient with a right-to-left shunt, you must use filters on IV lines, because any tiny air bubble can go straight to the brain and cause a stroke. Dehydration is a huge no-no, as it makes their already thick blood even thicker. And you never ever do a phlebotomy just for a high hematocrit number, only for real symptoms of hyperviscosity. So, after that whirlwind tour, what are the absolute must-know take-home points? Let's boil it all down to a few clinical pearls you can use on your very next shift. This one is huge. If you're looking at an EKG, a chest X-ray, or an echo, and you see a big right atrium or ventricle, and there's no obvious reason for it, you have to think about an atrial septal defect. It's one of the most common lesions to first show up in adulthood. Yes, I'm saying it again because it is that important. This simple physical exam move can uncover a totally treatable cause of high blood pressure. Don't miss aortic coarctation. It can literally change the course of a patient's life. This is maybe the most important mindset to adopt. These patients have a fragile, unique physiology. Something as simple as a routine procedure or an admission for pneumonia can be incredibly dangerous for them. Please trust your gut. Consult the adult congenital heart disease experts early and often. And that brings us to our final and most critical point. So you've found something. What do you do now? The answer, which really underpins everything we've talked about today, is to refer. Your most crucial job is not to be the world's expert, but to recognize the possibility of HDHD and get your patient to a specialized center. That single step is the key to making sure these patients continue to thrive for decades to come.